Ladies and gentlemen, welcome to this session, which we anticipate will be one of the most impactful sessions you will attend this Congress. Now, why do we say that? Because we will be defining what TAVI in 2025 looks like and beyond. And there is no differentiation between us here on the stage, the names and faces that you see behind you, and yourselves in the audience, because we are all stakeholders invested in the evidence-based care of patients with valvular heart disease. Now, over the next 90 minutes, together, we are going to be understanding how the new 2025 valvular heart disease guidelines are reshaping care and clinical decision-making. And we're going to engage with what is a needed paradigm shift in the contemporary management of severe aortic stenosis. And we will be gaining and sharing a truly global perspective representative of all of us here in this room on addressing the challenges but also the opportunities that exist from expanding our TAVI population. Of course, like ever, we really want you to interact with us. We will change our discussions to make sure that we meet your learning needs. Marty, would you like to provide us the evidence-based context for this session?
Thank you, Chris. I agree. This is going to be an exciting session. We have a wonderful panel. We have a great case, and I think we have a lot to talk about. But I must say I was breathless at ESC as they unfolded the new guidelines, because I frankly felt that my European colleagues really got it right. So I must say that Michael Borger, Fabian Praz, who was just here, and that team of people really came up with some very exciting new guidelines that now is beginning to direct a change in therapy and really does reflect what is now an acceptance and an amplification of earlier transcatheter treatment of patients with valvular heart disease, particularly aortic valve disease. So I'll mention 4 things, and I'll just mention them. Finally, we now have, as a mode of intervention for severe aortic regurgitation, the recognition that transcatheter AVR may be appropriate in symptomatic patients that are not surgical candidates. We now see a revision in the guidelines that indicates that we should treat younger, earlier, with preferred treatment, transcatheter aortic valve intervention, which is radically different than what we had seen in the past. We have now, for the first time, mentioned the importance of using TAVI in patients with severe bicuspid aortic valve stenosis. More work needs to be done, but at least it's an introduction. And finally, we've seen now the acceptance that intervention for asymptomatic severe aortic stenosis is being accepted with a 2A class, level of evidence A, as a new indication for treating these patients. So these are very important. Near transformational changes that we should all reflect on, and that's what we're going to be doing over the next 90 minutes.
Thanks so much, Marty, for giving us that context to this session. But of course, we're actually going to be interacting with a real-world patient, and we're going to see how we can apply those guidelines in a contemporary fashion befitting TAVI in 2025. So it's our great pleasure to welcome Philippe Généreux, who's going to be introducing us to the patient that we're all going to be looking after.
So it's my pleasure actually to present a case that will be done by Tanya Rudolph team from Bad Oeynsten Center. It's going to be a case about balloon expandable TAVI for asymptomatic severe aortic stenosis. This is a 74-year-old male who was diagnosed incidentally with severe AS during flu influenza hospitalization. He's clearly asymptomatic, very active. Is a cyclist, Nordic walking. You can see he has no other disease or risk factor. Is a fit man, we say rather tall, in cycling and walking on a daily basis. He is on no medication. His laboratory were normal with normal hemoglobin, no decompensation, heart failure with normal NT-proBNP, OBNP, and normal kidney function. There's a sinus rhythm on the EKG. You can see the echocardiogram with preserved ejection fraction, and I would say rather a very severe aortic stenosis with a peak velocity of 4.8 and a mean gradient of 62, an aortic valve area of 0.7, and I will say a preserved flow with a stroke volume index of 46. This is the CT scan where you have to pay attention where there's no calcium in the coronary artery with no lesion that exclude coronary disease. You can see extremely severe aortic valve with a calcium score of 5206. You can see here the CT scan. You can see actually it is a very good and suitable patient for SAPIEN 329 with a rather large annulus. You can see the area at 658. Very large sinuses, around 35 to 39. The STJ is also large with no excess of calcium. And importantly, both coronary are very high, 15 for the left main, and the RCA is 21. Again, you can see a very calcified valve, mainly restricted to the leaflet and the annulus, no extension in the LVUT or the STJ. You can see the right and the left groin. The femoral artery and the iliacs are suitable for transfemoral TAVR as well. So in summary, we have a 74-year-old male, very fit patient with no comorbidity. I would say really low risk, both for surgery and also for TAVI. The heart team, after discussion, and Tanya will discuss in a short video a little bit about the patient, decide to intervene after a shared decision-making process, talking about TAVR and SAVR. The decision was done to move forward with TAVR, and we're going to hear Tanya.
The patient was sent from his cardiologist to my outpatient clinic with the question if there is an indication for treatment, since the patient was absolutely asymptomatic. When I saw the patient first, he also denied any symptoms. And I explained to him that we have multiple options. So he could either undergo intervention or we could keep him under close surveillance. After explaining him the options, we agreed upon performing a CT scan and repeating the echo. The echo showed severe aortic stenosis, preserved left ejection fraction, and in the CT scan we could rule out coronary artery disease, and we saw that from an interventional or surgical point of view, this is a low-risk candidate. So we discussed the patient again in the heart team and agreed upon that the patient has an indication for intervention. And I took this information back to the patient and had a discussion with him and his wife, explaining to them the options. So either TAVR with a low risk, or surgical intervention also with a low surgical risk, or a close surveillance. And after explaining the pros and cons of the different options he had, the patient agreed upon undergoing TAVR.
Well, thank you so much, Tanya. Now we're gonna, before we go to the live case, we're gonna look a little bit more for this specific patient. What is the guideline are telling us, and what is the insight from the new guideline? So like Marty said, actually, this is the new guideline, and TAVI was elevated to a class 2A, level A evidence for patients with severe AS with no symptoms, joining surgical AVR, and now we talk about intervention, either TAVI or surgical AVR for patients with severe AS, no symptoms, that are at low risk for procedure. I would say that the guideline really did a great job and simplified the workflow. Really focus on if the patient of severe AS with symptoms should be treated promptly. If have no symptom and high gradient, should be considered for intervention with a class 2A, level A, either TAVI or SAVR, depending of the heart team discussion, the CAT scan, and the patient preference. The guideline also emphasizes that the stress test may be challenging to perform in community and lower their recommendation, and they mentioned to do it if feasible or appropriate for the patient. They recognize the challenge of clinical surveillance in daily practice, and like I mentioned, elevate TAVI as an option for asymptomatic severe AS for patients at low procedural risk. This evidence was substantiated mainly by the early TAVI trial, which is a large randomized trial of 901 patients comparing early TAVI to clinical surveillance that demonstrate the superiority of early TAVI related to the endpoint of death, stroke, and cardiovascular hospitalization with a 50% reduction of this endpoint, and also a 70% reduction at 2 years of heart failure hospitalization. And when we put all together the 4 randomized trials on the topic of severe AS, no symptoms, this is where we see a 70% reduction of heart failure hospitalization, 60% reduction at cardiovascular hospitalization, and also 40% reduction in stroke in favor of early intervention compared to clinical surveillance.
Thank you very much, Philippe. And I think that's one of the first times in this main arena where we've seen such context given to shared decision-making between the patient, the treating physician, and the heart team. And so, Kentaro, based on what you've heard, what you've seen, you're bringing in the anatomy, the asymptomatic status, and the shared decision-making process. Do you agree with the overall strategy to offer intervention?
So thank you very much, Chris. So I totally agree with proceed to the intervention because the patient is the asymptomatic. Maybe we can think about the potential avoidance of the heart cardiac damage or heart failure hospitalization. And the good news of this patient is the aortic valve complex is quite forgiving and spacious, and he can receive the second or potentially third valve if when necessary. And he also had a very good iliofemoral access. I agree with to proceed to the transfemoral TAVI with the SAPIEN tray UR.
Okay, so there's great points there, is that we've really brought in both the evidence, but also the anatomy in this patient. We'll come back to your concept of forgiving anatomy for future revalving, because I want to ask you first, is there a particular valve type that you would implant in this patient?
So for me, I think it's better to choose the balloon expandable SAPIEN because it enables the repeat procedure of TAVI. Because this patient is 74 years old, we still see some possibility for the repeat intervention. I think it's quite important to secure the possibility for the repeat intervention as well as the coronary access.
Understood. And I guess a bigger question then is, based on what we know from the data, we're data-driven physicians, can we only implant one particular valve type in asymptomatic patients? It's a big question. It's a question that we need to ask ourselves as a field. And I know someone who knows a little bit about clinical trials in asymptomatic patients. So Philippe, I'm coming to you with your trialist hat on. What's your interpretation?
So this is a very important question. Obviously, as a purist trialist, I will say that we test the hypothesis with a set of equipoise with a balloon expandable valve, and we show the superiority with a balloon expandable valve compared to surgery. So as a trialist, as a purist, I will say that the indication should mimic the study population, the study device. That being said, when we look at the guideline, they talk about intervention, they talk about AVR, they talk about TAVR, they don't talk about specific surgical valve. So if I wear my practical hat, my clinician hat, I will say that the important thing is to treat AS promptly with AVR, whether it's surgery or TAVR. I will say that it's better to treat AS with another type of valve than not to treat AS. And I think as a practicality, and like the guideline did, it's AVR as a whole is a procedure.
That's a really good point, because the guidelines speak to AVR. Yes, this patient is being treated with TAVI today, but it's about replacing the disease. It's about replacing the valve. And the guidelines and the perspectives are agnostic to whether that's transcatheter or surgical. But Ferdinand, you do both types of these procedures and operations. So what goes through your mind as someone who can offer this patient both surgical and transcatheter? And are there any other considerations about what your choice might be?
So actually the main point, in my opinion, is that they have an early onboarding of the patient to the outpatient clinic and that they have assessment through the clinical interventionalists. So you get a good point of view, you have good diagnostics, you have the CT scan, and then, of course, you have a shared decision-making by the heart team that you're going for an intervention that you want to treat the disease. And then, of course, there are different options for this patient. But from a surgical view, I think both options are legally correctly. And of course, the guidelines are now clearly, and if we have a big size in that patient, a tricuspid valve, of course, a TAVI prosthesis, a big TAVI prosthesis is an optimal treatment for this patient.
Yeah, can we explore that further? So we've discussed, Kentaro also mentioned this, that the large annulus anatomy here is favorable for this patient. Ferdinand, could you expand further why that's a useful feature?
So we have a big estimated aortic valve area. Then we have a tricuspid valve, so it suits really, really good for TAVI prosthesis. There's maybe one topic that we have a lot of calcium load. So this could be favorable also for a surgical approach to excise the valve and put away the calcification, and maybe avoid some strokes in that case. So if we would have different conditions with a smaller annuli, something like that, or hostile TAVI conditions, then of course surgical options come forward, in my opinion. Yeah. But we have to discuss it together, seeing all the pictures, seeing the CT scans, and find the best way.
Chris, we have a very active audience. I already have 8 questions here, and they're very relevant. So this is not only active, but a very insightful audience. So I'm going to ask some questions, and this will be like playing a quiz game. We need short answers, and anybody who raises their hands can answer first. This patient has pretty severe AS. It's got a mean gradient of 60, peak velocity of 4.8. 5 years ago, all we talked about was sudden death. Why doesn't anybody introduce the issue of sudden death as being an augmented risk factor in somebody with very severe AS in the discussion? Is it relevant?
Well, I think this was recognized to some extent by the guidelines. For this type of patient, there was already for a long time in both the European and American guidelines a two-way indication for valve replacement with severe AS. And I agree, this is a patient with very severe hemodynamic AS and as well very severe calcification.
Yeah, but I would say that as we follow more and more patients, the incidence of sudden death is not as great as we thought it was previously. So we're not emphasizing that as much in the discussions because it seems to be a little bit less of a clinical problem than we once thought. Second question, why did we bypass the stress test in this patient? You have an asymptomatic patient. Why didn't we do a stress test?
That illustrates a little bit the limitation in the implantation, the low incidence of stress tests in community. Rarely a doctor will do this. In US, it's 15% penetration at best, similar in Europe. So this patient was extremely active, potentially didn't see the need to do a stress test. But we probably will have learned a lot with a peak velocity of 5. His blood pressure may have dropped. He may be dizzy at some point. So if you push the patient, this is a good question, but this is reality. People don't do stress tests. And if you have a positive stress test, mortality go twofold increase.
Is a stress test risky in a patient like this?
In early TAVR stress tests, more than 1,200 patients, no sudden death, no CPR, no VTAC. So it was extremely safe.
So that mystique about the risk of doing a stress test in these patients needs to be completely debunked, and we need to emphasize if you choose to do a stress test, it really is not a matter of increased risk. One final question, which I think is entirely relevant here. If you intervene in a patient like this, there's a lot of calcium in this valve. Does that calcification change your approach from the standpoint of cerebral embolic protection, predilatation, those kinds of things? Anyone?
I think what we are going to do is to guarantee a full expansion of the implanted prosthesis. And this is why, and also to allow the smooth passage of the valve. And this is why predilatation, with a sizing, not undersizing of the balloon, but a proper sizing according to the annulus, will matter, just to allow a proper full expansion of the valve. Second is that we should also probably prolong the inflation of the balloon to allow full expansion and find the recoil, and consider double tap to also to counter any recoil of the frame. So this is all to reduce the gradient and to guarantee the possibility of a future redo in this patient.
I would say in US, this patient, we use maybe 5% of neuroembolic protection, but this is the patient in the 5%. We use it when there's a lot of calcium, the patient is young, when you're going to pre-dilate and potentially post-dilate with a lot of manipulation. I would say the evidence is not as striking as we want, but this type of patient, this is where we use neuroembolic protection.
Okay, I want to thank the panel, and I particularly want to thank the audience for really bringing that heart team discussion to life. I've just heard in my ear that our fantastic live case operators are ready with our patients. Good morning, Tanya,
Hello,
Sabine.
welcome.
Nice to see you.
Yes, hi. Nice to hear you. We can hear you quite well. It's a great honor for me to be here as a guest back in Bad Oeynhausen at the Heart and Diabetes Center. We are here in OR number 5. And I'm here with Tanya Rudolph. She's an interventional cardiologist. I'm a cardiac surgeon. We also have here a catheter nurse, Ines, and also Nadia in the room. And the anesthesiologist, Katharina, helping us with the patient. The patient is under conscious sedation and with local anesthesia. And our strategy for this asymptomatic aortic stenosis patient is to achieve an optimal hemodynamic result with a TAVI, with a short frame valve, leaving open all options for the patient concerning coronary interventions or even redo TAVI interventions. And what we have prepared so far here is the radial artery was punctured with a 6 French sheath for the diagnostic pigtail catheter, and we have a venous sheath with transient pacing wire. And we will now start with the procedure. Tanya, would you like to
So
go
absolutely,
ahead?
yeah.
And so what we are doing here is now just the standard procedure.
Exactly. So the first step would be an ultrasound-guided puncture. So you can nicely see that here is the bifurcation. The vein is underneath, and we just go 1 to 2 centimeters above. And as you have already seen from the CT scan, there is really no calcification, large anatomy. And so I think this would be a good spot to puncture. Now you see here my needle coming on top of the artery. I really try to stay in the center. You can see that now it's in the middle, and I puncture, and we introduce the wire. And may I ask for heparin, please?
And the valve can be prepared.
And so, I mean, you were already discussing about the strategy and also regarding calcification. So we also have the impression that it's a severely calcified valve, even though it's very symmetrically distributed. We might think about pre-ballooning here, and we have already somehow near us a 22 millimeter balloon. And usually what we do, we decide upon the intravenously measured gradient if we go for pre-dilatation or not. But I think Sabine might be pretty likely that we do that.
Yes, because on echo the gradient was 60, which is really quite high.
Yeah. And so here we introduce now the pre-closure system, a pro style. So we usually use 1 in the first place and assess whether the closure is sufficient at the end. And if we need 1 more, then we introduce either 1 more pro style or an angioseal. So as we expected, no problem here because there is no calcification.
Yes, and this anatomy is really favorable for a transfemoral procedure with very large vessels and straight anatomy, no kinking, no calcium.
So now we exchange the pro style for a 10 French sheath. and introduce an AL1 catheter here.
I just want to mention that watching the step-by-step approach is very instructive for us. And actually starting from interrogating the vessel, doing your arteriotomy, placing the catheters, all that I think is very, very instructive for the audience. We're not going to interrupt you intentionally. If you have any questions of the panel, please feel free to ask, but we want you to kind of direct how the conversation should be. And by the way, thank you also for... I mean, we have a panel which is all men, and by having the two of you doing the procedure, we really appreciate that you've truly helped us to restore the gender balance of this procedure.
Yeah, we are also happy about that, to be honest. So I know there are not so many female operators, especially not two of them, I think. So we are also happy that we're here together. So what we have done now, we introduced a pigtail catheter, and you see it nicely. It's now on the aortic valve. I connect.
We really see that calcium even on the fluoroscopy there.
Yeah.
Yes. But although the valve is very heavily calcified, the calcium distribution is very symmetric. It is a tricuspid valve. There is no LVOT calcium, so still, I would say this is a low-risk anatomy for a transcatheter procedure, but of course would also be very feasible for a surgical procedure.
Yeah, for sure. And I mean, this is, I think, also something you pointed out already during the discussion, that in a case like this, you have to discuss all the options with the patient. You have to make sure that he understands what are the pros and cons, and that the patient can really make a good decision. So now we will show you the angio. And I think also here you can nicely appreciate that it's really a huge anatomy. So we were using 8 milliliters of contrast, and you see it's not completely filled up here. So the next step would be to cross the valve.
And can
so
we
maybe
ask,
Ines, you can...
Can we ask, has the patient still got maintained left ventricular function during the case today?
Yeah.
And approximately how long was the patient pathway from diagnosis to being treated with us all here today?
Yeah, so the thing is that he basically had the influenza infection, and this was in May. And at that time, not really a proper diagnosis was made. So they just told him that there is a murmur, and there might be something wrong with his aortic valve. And so he got an appointment because he was completely asymptomatic. He got the appointment in 2 months later at an outpatient cardiologist, and so then it took another 6 weeks that the patient was brought to our center for further assessment. And also, I mean, the question came up why we didn't perform stress test. I think this is at least what we heard when we were listening to you. And so usually we perform a stress test, but this patient told me that he is doing cycling tours, 80 to 100 kilometers. He lives very actively with his wife, who is 8 years younger. And they are very active, really doing sports. So I thought in this regard, it would not make so much sense, because I was so convinced that he is really asymptomatic. We were discussing this before, Sabine, right? That maybe we would have done the stress test if the patient might have denied to undergo intervention, because we also had the feeling that regarding very severe aortic stenosis and already having left ventricular hypertrophy, from a prognostic point of view, it's beneficial for the patient. So now coming back to what we have done so far, you see that we crossed the aortic valve, and now we exchanged it for a pigtail catheter, because here we definitely want to do the assessment of the invasive gradient. And maybe you can pull a little bit on the wire, and you see he's already getting extra beads. Doesn't like that too much. I will flush the pigtail, the other pigtail soon, to get the right pressure here in the aorta.
And we're certainly expecting to see very significant gradients here based on the transthoracic echo data, but this will be very important baseline hemodynamic data for us also to assess the success of the procedure as well.
You know, believe it or not, we still do a fair amount of transesophageal echo with our TAVIs, particularly the complex patients. I think we call it the Becky-Hahn effect. But I will say that when you have general anesthesia and TE echo, the hemodynamics are a little bit more difficult to interpret. So really, when you have these patients with conscious sedation, it's a little bit more the normal ambulatory hemodynamics that you see.
Yeah. So, Sabine, you want to comment?
So the gradient now is 40, and we were discussing we would definitely do a predilatation if it is 45 to 50 in the invasive. Now it's below. What do you want to do, Tanya?
Yeah, that's a good question. So maybe we
can
give
ask the audience.
Yeah, we have really a very experienced panel. So, what would be your advice?
Yeah, with pleasure. So we'll take you through the panel now.
I would say that I will recommend a balloon valvuloplasty here, just because I want to minimize the pushing and pulling of the system. Sometimes it's hard to cross, and there's a lot of grinding of the valve, and this is why you may embolize some stuff during the valve positioning. So I think that's going to make everything easier, and maybe paradoxically decrease the trauma in the grinding of the valve with the TAVI valve. I can go either way. I don't think there's a wrong answer, but this valve is very calcified, so I will go with the BAV.
So I agree with proceeding to the predilatation because the patient has really high calcium score. We can do either way, but I prefer to do the predilatation for this patient.
So actually, they have a protocol with their gradients to predilate or dilate or not, and the passage of the valve was quite easy. So it took 20 seconds to pass the valve. This is also sometimes an indicator for me personally if I should predilate or not. So if the valve passage is easy and the gradient isn't that high, maybe you could skip the predilation also to avoid maybe strokes or something like that. So.
Okay, so we have 2 votes for predilatation. I'll add my name to that as well, actually. And I think we're focusing here on as near perfect result as we can. So I think valve expansion at the end will be facilitated by predilatation, as well as, to Philippe's point, issues around crossing and making sure that we're trying to reduce stroke rate as much as possible. But of course, we're here to support you in your decision in the lab.
Of course. But I now think, as most people voted for the predilatation, we will do it.
Yeah, I think it makes sense also in the big anatomy. I mean, as you said, sometimes it's difficult to cross the valve. And so, I mean, it felt quite smoothly to cross it with the wires and the pigtail. But I think it's a good advice here. And we want to make sure that the patient really has a perfect result in the end and that we can really nicely position the prosthesis. So now this is a regular safari wire. We do not any extra support here in the groin because there is no tortuosity. So that's not an issue. You see that he really doesn't like it that much, so a lot of extra beads. And now we exchange the 10 French sheath for the E sheath.
I would say it's not infrequent and very, very thick ventricle, high gradient, small women also to see this level of ectopy in very high gradient.
We sympathize with you regarding the ectopy. It's something that happens and wire position can help, but ultimately, you know, this isn't going to be causing any significant problems to the patient.
There's a comment from the audience that they observed that the LVEDP was very, very low. And maybe that was at least one of the explanations for the lack of symptoms in this particular patient.
Yeah, I think so too. I mean, also we had in the echo not really a hint that there was a diastolic dysfunction. So I think we might have been picked up this patient really early in his disease state. So we would do a predilatation. So we need rapid pacing soon. And we have now here a 22 millimeter balloon. So I think it's not necessary to be too aggressive. It's just to facilitate the valve crossing. We use a true dilatation balloon here. Okay, ready to go?
Yes.
The wire.
He's really very sensitive.
Sensitive, yeah, absolutely.
Sensitive male heart.
Sometimes they are like this, so. Okay, so you see the two markers. I just corrected the position of the pigtail. Should be in place. Okay, you are ready? Katharina, you are ready? Okay, so rapid pacing on. Okay, so rapid pacing is on. We open up the balloon and off, please. Okay, so patient is recovering quickly from rapid pacing.
Excellent. And there was very clear communication in the lab there, very calm and controlled. Other panel, are you happy with the predilatation that you've seen?
Yep. I think it's quite important to put the pigtail catheter in non-coronary cusp to avoid a potential risk of the acute AR. They did a really good predilatation.
Yeah, we agree. And also to your point earlier, Tanya, this is predilatation to ensure passage smoothly of the device. We're not doing the type of predilatation we would need for a self-expanding platform, for example. So you're doing a great job.
Yeah, absolutely.
Yeah, absolutely. I mean, this is also our regular strategy. And now here we have the SAPIEN 3 29 millimeter valve. We check on the orientation after the crimping, everything's fine. And we also agreed upon using a Resilia valve in this patient for longer durability. And now we would introduce the system. Once again, before doing that, I check on the wire position. It's fine. So I introduce the delivery system into the E-sheath and slowly advance it. You need a little bit of push here to dilate the E-sheath, but it's going smoothly. Sabine is doing a great job of controlling the wire. We do not have as many extra beats as before.
And your hemodynamics look like they've recovered brilliantly, and the QRS remains narrow, so you're in really good shape.
Yeah, so now you see the valve and the balloon. We will now load the valve onto the balloon. The wire. Okay. I just advance it a little bit more, then we can see it better. Now we do the fine adjustments here, turning the wheel towards us. And now you can nicely see that the balloon is traveling down into the valve. A little bit more, I would say. Maybe we push the wire again a little bit. Yeah, it looks perfect to me. So I think we are well aligned. We reduce the tension, and Sabine gives already a little bit of torque. We go slowly across the arch, pull on the wire. And now you can see that's not an issue here. And now we stop just in front of the valve, and we would check the position of the pigtail. I think we have to take into consideration, since it's so heavily calcified, that the pigtail is not really at the bottom end of the non-coronary cusp. So if we go in now and place the middle marker at the annulus, I think we should consider that. So now I go into the valve, and this goes nice and smoothly. I do not really need a lot of pressure here. Maybe we get one, zoom in, so that's better to see. I think that's easier to see. I think that looks very nice. Now we retract the pusher. You see that the pressure goes down a little bit, so there is some sort of obstruction here. Maybe this also, predilatation sometimes also helps you to give you a little bit more time to do the positioning, because it's not so tight anymore. So now this looks, I would say, okay-ish. I try to...
There is a question from the audience about whether you use 1 or 2 implant views in a case like this.
So in a case like that, we use only 1 regular. We have a little bit of parallax. Maybe we get rid of that.
And that's a really important point, to make sure that your valve is now in plane.
Yeah,
and so
good.
the team are correcting for that, to really precision height deployment.
So we still have time. The pressure is good. And now you see that we have to go a little bit deeper. Maybe, Sabine, you can hold a little bit the pressure here, and I just try to reposition the pigtail. Now that's much better. And we go a little bit further in, maybe like that. Check again.
The pigtail does not come down 100%.
Yeah. So, but I think I would do it like that. So.
Yeah.
Are you happy with that
Yes.
position? And I think you can already see that there is severe aortic regurgitation. That's so we are opening up completely the valve. Okay. Happy with the position? Is the panel happy with the position?
Supportive nods
more
here.
time.
Yeah.
The trend in the United States is to go a little bit higher, but this...
Yeah, but I think... So you agree that pigtail is not completely at the bottom because there is so much calcification.
Yeah,
it's a little bit higher, the central marker.
Yeah,
And we do not have parallax.
Yeah, you're just above the lucent line. It's a 29, so it sort of sometimes foreshortens proportionally slightly more. So I think we're in agreement. This is a good height.
Okay. Okay, so we need rapid pacing. Rapid pacing on. Okay, KM. And now we really do a long inflation, deflation, off, pacing off. Okay, so we let the patient recover. We retract the delivery system into the ascending aorta. And the first thing we check is somehow the expansion of the valve. Can you give a little bit push? Yeah. So, and just from the first impression, I would say that it's nicely expanded, because we were discussing the double tap technique before. So I think here there is no shortening in any projection. We could also go to RAO and see.
Yes, you want to do it?
That's a great idea. So I agree. The expansion looks very nice so far in this view, but it's always important to check in another view, such as the RAO caudal, to be able to see you expanded in 2 planes. The hemodynamics look good. The ECG hasn't changed at all to my eye. So I think we're in an excellent starting position.
So, this is now an RAO caudal. And here, you can also see that it looks well expanded. So I think, you did a good inflation. It opened up fully. So I would not do a double tab here.
Diastolic pressure is 66, so let's
Yeah.
have a look at the
Yeah.
hemodynamics.
Can we go back? So we retract the delivery system.
So Philippe, any comments so far? Happy with what you've seen?
So far, so good. I think I agree not to do a systematic double tap. You have the wire, you can do the hemodynamic and assess. We try to minimize manipulation of this valve, giving the burden of calcium, and they did a good predilation. I will say that the only thing I will have done different is maybe pacing on the LV wire. This patient had no conduction disorder, narrow QRS sinus rhythm, no LVOT calcium. So we have the habits to use LV pacing in this type of patient and put a venous pacemaker if there's a left bundle or right bundle or severe MAC or LVOT. But I like the safety net or RV pacing as well. So
If there are no conduction disturbances at the end of the procedure, we will remove the wire. And the patient goes to the normal ward without any wire.
So now we do invasive assessment and also assessment by echo.
So that's great. So you have echo in the lab as well.
Yes, we do. That's our regular routine procedure that we assess also the hemodynamics by echo. I just want to make sure that there is not so many extra beats. I think this looks better. Still very sensitive.
And that makes a lot of sense because remember, the day one assessment of the hemodynamics will be performed by echo. So if you know what your echo baseline is in the lab, of course it will be slightly higher the day after, but your assessment of paravalvular leaks, if present, are all going to be transthoracic echo-based.
And as you mean, with the invasive assessment, you see that the transvalvular gradient is 2. There is a nice separation between the diastolic pressure in the LV and the aorta. So it's not super likely that we have a relevant PVL. So as you see, of course, sometimes transthoracic echo is a little bit challenging because patients are lying on their back. But Mohammed here is doing a great job and giving us some impressions here. You see really still preserved ejection fraction and no relevant PVL, as we can see so far.
And clearly that left ventricle has been working incredibly hard against this very stenotic valve. And you can see those changes in terms of the LV morphology.
So invasively, we had a gradient of 2. By echo, we have a gradient of 7, something which we also see quite commonly. So, I mean, from echo and intra-invasive hemodynamic, I mean, we would be happy. So we would proceed to the angio.
I think you were you were a little hard on yourself on the echo tracing. It was after a long cycle, an ectopy. I think the gradient is probably 4 or 5, like the other beat you trace. So I think this is a beautiful result.
Yeah. Well, but you better be hard to yourself, then you are not disappointed in the future. So
that's right.
Okay. So we place the pigtail here on top of the valve and do an injection with 30 mils. Okay, so, I mean, I do not see a PVL.
I think it's completely perfect.
Yeah, and, well, I think the position looks pretty good to me. So it's a rather high position. So because we wanted to avoid, of course, in this rather young patient that he develops conduction disturbances. So, I mean, here I think there is nothing more to do. So we would proceed here and get rid of the E-sheath. Can we give Protamen, please? So we regularly always reverse the heparin by protamine. Without. And so then we always check on the excess, and we use a 6 French sheath. And you can already see if I just pull very gently on the suture here that it's already almost closed. And now we introduce the 6 French catheter. And so this looks nice as well. And now there is no extra bleeding here so far with the 6 French sheath in place. And now we will check. Okay, we can go now to the groin. So, Katharina, are you fine with removing the pacemaker? Yes. So we would do that because then we can also assess better our puncture site. You see that much better? Okay.
Okay.
We are adjusting just the C-arm. A little bit further. Okay. Ja, maybe a little bisschen noch fußwärts. Yeah, okay. Good. So,
Rechts oben.
here we go. So this is the evaluation of the excess, and I think you can nicely see what we have done here with the ultrasound-guided puncture, that we really hit the vessel where we intended it to be punctured. So, I mean, can I get the wire back? So, and then what we usually do, we reinsert the wire, and if it's dry already with 1 ProGlide, we do not go for any additional closure system. If it's not, then we would use Angioseal. Okay. You want to remove the sheath? So this looks already good.
I remove the wire.
I think you can. Okay, I tighten.
Okay, I think with this,
Yeah. Okay.
we finished the case. Are there any further questions or comments from you, from the audience, from London?
Well, I'd just like you to know that it's standing room only here in the main arena, and you've just demonstrated beautifully not only the workup and care of this patient, but a fantastic transfemoral TAVI procedure with an excellent procedural result. So many, many congratulations. Thank you so much, both. And on behalf of the Congress, we really thank you for your contribution. Goodbye.
Thank you, goodbye.
Bye.
It's interesting. Usually after a case, there's a lot of animation. Everybody's wanting to ask questions. There was just silence. So I think, as you said, Chris, this was truly an excellently performed case by 2 thoughtful, experienced operators that took us through step by step in less than 30 minutes, skin to skin, a TAVI procedure in a patient who has severe asymptomatic AS. Just a few comments about the procedural technique. I think there are subtleties that people do differently, but those subtleties really don't make very much difference. What I liked was the very thoughtful examination of every step and doing the things that people felt comfortable with. It was a pragmatic, efficient, and well-conducted procedure from the point of initial vascular access to the point of closure. The decision about predilatation was very thoughtful. The location of the valve size, I think, was done very carefully. The assessment of paravalvular leak was probably even a little bit more rigorous than many people in the US do it, and the result was excellent. There was no evidence of frame deformity. The gradients were extremely low. There was none trace paravalvular leak, and the vascular access site looked essentially untouched with a single ProGlide. So I think that, my compliments to the operators and to the team. This is really a very good team. One of the questions that was asked was, in a procedure like this, in a patient that is fairly young and has good anatomy and no significant comorbidities, do we really need two operators? Do we really need a surgical assistant in the room? So this is a question that was asked. I would respond by saying, if the surgeon is Sabine Bleitzefer, the answer is yes.
Absolutely.
And just her comments after the valve was implanted, that this was a perfect implantation, to have a surgeon say that is very reassuring to a structuralist.
Also for the patient to hear, because they're only under
Yes.
conscious sedation.
Yes, yes.
Okay, so Radoslav, we've had our little debrief, but we're really looking forward to see what your procedural analysis is as well.
Mm-hmm. Thank you. So I'm going to describe a very stepwise approach to the procedure, which was focused on safety and precision, and which I'm going to go through with you step by step. So you are the eyes of the operators, and I'm going to analyze the procedure with you. The first screen which we saw was showing the femoral access, and what we saw is that the team used the femoral venous access for the insertion of the right ventricular pacing. We could just ask ourselves why, but we saw already that the valve was heavily calcified. One of the tricks to facilitate crossing in case of failure with a hydrophilic wire is to pace from the right ventricle in order to open the leaflets during the pacing and to facilitate wire crossing. So this is why when I was watching the femoral access, I saw the venous access as well, and probably this was just to facilitate the aortic valve crossing in case of wire crossing failure. Second is that we saw only one prostyle used for the pre-suturing, and this reflects the current trend to minimize the pre-closure and to assess whether we need to add additional closure device at the end. So this is what the team did in Bad Oeynhausen, using only prostyle at the beginning. Then what we also saw is the RV electrode being used to guarantee the safety is, of course, a balloon-based one, just not to put any strain on the right ventricle and not to cause any procedural problems. And I agree with what was said, that currently we do LV pacing, but let's keep in mind this was an asymptomatic and low-risk patient, so probably this gives additional safety margin. Another thing was the wire crossing, and I was focusing on the precision of the crossing, because in heavily calcified patient without any device preventing from the stroke, then we are not just doing several touches of the aortic calcium, but we are just trying to target the central part of the valve and just to detect the flow with a wiggle of the hydrophilic wire, which was passed very smoothly in this patient. Another step was the exchange for a stiff wire, and I was observing how the stiff wire actually adapts to the outer curve and then goes through the aortic valve, because we can assume or suspect that the calcium located here in this non-coronary sinus actually was moving away the wire to the central position, and this is an indicator that we should do a predilatation on top of what we were discussing earlier for the optimization and full expansion of the procedure. Going further, this kind of impact on the system from the non-coronary sinus calcification was also visible by observing the pigtail, because usually I push on the pigtail trying to see if this adapts and touches the non-coronary sinus. However, the pigtail was kept in the center, and this was also an indication in favor of predilatation. As for the predil,
we observe the proper balloon expansion, and if there is any waste occurring at the level of the annulus, and also the region where the calcium is located. Of course, the indentation, the waste of the balloon, depends on the C-arm projection used, but here actually we saw no waste leading towards the use of the predefined and pre-selected size of the SAPIEN 3 Ultra Resilia 29. Another safety measure for anybody starting with a system is that Tanya stopped at this moment, and also Sabine, to watch the proper alignment of the valve and proper loading of the valve, because this is the last time the operator sees the skirt of the crimped valve in the system, in the loader, and then cannot identify the position of the valve on a crimped commander balloon. Then also, during our talk, Tanya stopped with a valve without crossing through the aortic valve. And the reason was that we saw that as soon as they crossed through the valve, there was a blood pressure drop. So in order to decide and to explain in the cath lab what to do, we always park the system above the aortic valve. Further on, we saw the blood pressure drop when they crossed when they crossed the valve, and all the discussion came, how do we position the valve, with a US experience telling that we should go higher, and Tanya being in favor of going lower. But I was just following her mind of, okay, what drives her to go lower? And the answer was, and I will tell you on the final slide, that we should prepare for redo in this patient. There was no conduction disturbance in this patient. She could afford going a bit lower to allow a margin of coronary access against the STJ, just to dive with the top of the frame below the STJ, because the future risk plane for this valve will be at the top of the frame. So then what we saw was a prolonged inflation. And this is one of the options which you have, is either prolonged inflation in a patient with a good left ventricular function, or to do double tap to facilitate the full expansion of the valve, and to allow and to tackle recoil. So you can see that she actually counted to 7 while expanding this valve. And further on, what we also could see that they used 2 contralateral projections to understand whether a double tap is needed. And also what I saw, and you can see it here, that we see 2 posts with a suturing, meaning just overlap with each other against the LCA just in front of it, meaning that we can assume in this projection that the coronary sinus is located towards the LCA, and also indicating that possibly they also achieved a proper commissural alignment. What we also saw further on is that they measured the pressure gradient, and the localization of the catheters was very proper, because they measured the gradient just above the frame and, of course, in the middle of the left ventricle. And finally, going towards the future of this patient, we can see a very well expanded valve with a proper depth of the implant. But this is what the operators also observe at the end. What's going to happen in 10 years' time? When you implant another valve, the neoskirt actually is positioned not directly at the top of the frame, but just here at these small points of the crown. Meaning that 2 things. First, there is a bit of coronary access also outside of the frame. There is, of course, ample coronary access from the middle of the frame, but if we do, and the patient proceeds to redo TAVI, the leaflets will stay open up to here, and then there can be a flow around the top of the crown of this frame. And this is why a bit deeper implant in this narrow STJ was favorable for this patient. So finally, just to say, the SAPIEN 3 Ultra Resilia 29 introduced a skirt which is higher and reaches just as the rest of the
frames, the middle part of the frame of the valve, and this is why a deeper implant was also good because of the frothy skirt, which prevented from any paravalvular leaks. Thank you.
Thanks so much, Radoslav. Very, very informative. So we have one question which keeps coming up on the chat, and we need to address that question, and it's about double tap. Should we? What's the reasons why? What's your practice?
I didn't adopt the double tap yet. I may change my mind, but with continuous hemodynamic pressure, I think, and good expansion of the valve like we saw visually, and sometimes we use a TE, it's maybe not necessary, but it seemed to have a benefit in recent studies. So I may change my mind, actually.
Great. And how about, Kentaro, your practice?
So actually, I'm not doing the double tap on a routine basis because I usually keep it to 5 seconds, slow 5 seconds to inflate the valve. And of course, we also need to confirm that the valve is well expanded. As far as we can expand the valve very well, and there is no PPL, and the pressure gradient is good. So I think that it's not the routine basis. I perform the double tap when necessary.
Interesting. So, I mean, like everything in life and medicine, it's never black and white, is it? It's about using all of that information to decide whether you will perform double tap, which, as Philippe says, some emerging evidence of short-term potential benefits, but who knows whether that changes the leaflet architecture with another high inflation. We don't quite know yet. Okay, so we've really watched this patient come through their journey. We've heard all about incidental finding. Really interestingly, we heard from Tanya and Sabine the amount of delay that was then subsequently incurred by the patient. Access to diagnostics, uncertainty about referral to the general cardiologist, until subsequently they were detected by the team at the Heart Valve Center, who then really accelerated that patient's care and brought them through to the procedure, which all of us just witnessed with a fantastic result. This sets the scene perfectly for our next speaker, who is going to be Philippe Pibero, and he's going to be talking to us about how we're changing the management of our patients. Philippe, we welcome you to the stand, and we can't wait to hear what you say.
Thank you very much. So the 2025 European guidelines, as Marty and Philippe showed, mark an evidence-based inflection point in the management of severe aortic stenosis. And these guidelines is a catalyst for a paradigm shift from passive to proactive care pathways. And the objective of this global expert perspective that I'm presenting today was to provide an operational framework to deliver guideline-directed care. And this is a blueprint for contemporary and future best practice. So one of the most important new recommendation in the 2025 guidelines was this new indication, class 2 indication, level of evidence A, that is supporting prompt intervention, TAVI or SAVR, for a broad group of patients with asymptomatic severe AS. And again, this is a catalyst for change from the previous default management strategy, the watchful waiting, to a more proactive management. With watchful waiting, symptoms have not only been the trigger for AVR, but also for action and referral. And the limitation of watchful waiting is first that there are some often misclassification and underestimation of AS severity, especially in women with low gradient AS. And then there are uncertainty and underreporting of symptoms. And then there are delays from the recognition of symptoms, such as we saw in this patient, to referral for AVR. And then again, delays from referral for AVR to treatment with AVR. And these delays, actually inaccurate diagnosis and timely referral and treatment, result in increased mortality, increased hospitalization, increased cost, and worse quality of life for the patient. So we believe this is an impetus for a transition from a passive watchful waiting to a proactive management. And so we propose this international expert perspective that was led by Chris Cook and Brian Lindman, and that advocate for a proactive management and treatment of aortic stenosis. So this proactive management pathway includes 5 pillars. First, and this is maybe the most important one, early referral. Early referral of all patients with suspected severe AS, and that should be symptom agnostic. Then a streamlined evaluation by the heart valve team to confirm AS severity, to assess procedural risk, and to categorize the AS severity. Then upstream testing and upstream preparation of the patient for the procedure with gated CT, dental care evaluation, and then prompt and accelerated AVR with a shared decision-making process to favor prompt AVR in the asymptomatic severe AS patient and accelerate AVR for symptomatic patients. And for those patients where deferral of AVR is considered, well, proactive surveillance, not watchful waiting anymore, but proactive with a partnership between heart valve team and referring clinician for effective surveillance. So we propose this proactive management pathway, and this is the central illustration of the paper. And the first step, again, is early referral. Early referral of the patient if any criteria, echo, imaging, or CT criteria for severe AS is present, regardless of symptoms. Why? Because we often have measurement errors in the echo assessment of AS severity. There is often discordant grading where some parameters are severe, but the other one are non-severe, especially with the low gradient AS, where you only have the valve area that is severe, the rest is not severe, and most often the cardiologist will conclude that this is non-severe. Also, symptoms are overlooked or minimized. How? Well, we can leverage AI tools to screen, to identify this patient with suspicion of severe AS. And then from there, we can generate electronic provider notification. And this has been shown to be successful in the DETECT AS trial. And we need to facilitate the transition from an opt-in to an opt-out referral pathway. Second step, a streamlined evaluation by the heart valve team. The responsibility of the heart valve team at this stage are to confirm and clarify AS severity by primary diagnostic, TTE, CT, and then also secondary diagnostic if needed. Then assess procedural risk, and then determine treatment strategy and timing and lifetime management. And then another important role of the heart valve team at this stage is upstream preparation for AVR, to win time and avoid delays again, including dental care referral and CT angio to plan the procedure. And this is ultimately a shared decision-making process with multidisciplinary evaluation with patient-centered decision-making. Then procedural risk assessment, which is different from surgical risk assessment. We need to confirm that there is a low procedural risk in this patient. And in TAVR, this would include most patients with suitable transfemoral access with tri-leaflet aortic valve morphology with some bicuspid with favorable anatomy. For SAVR, this would be defined as STS predicted risk of death less than 3%, no frailty, no major organ compromise. And this is, in fact, the majority of patients with asymptomatic AS who have a low procedural risk. We also propose a simplified classification of AS severity and categorize the AS severity into 3 main categories: the high gradient severe AS, that is the most straightforward. And then for low gradient AS, well, there is some more work to do, and often the primary diagnostic, the resting echo, is not sufficient, and you need to do a low-dose dobutamine stress echo, and CT calcium score is more and more used to confirm the stenosis severity and eventually confirm that this low gradient AS is severe. And in some cases, well, the heart valve team will conclude that the stenosis is not severe. And based on this categorization of the AS severity, we propose a timing of planning of treatment, which is evidence-based and aligned with the guidelines. And for the symptomatic severe AS patient, certainly we need an accelerated AVR pathway done ideally within 1 month. For the asymptomatic severe AS that we're discussing today, we favor a prompt AVR within 3 months optimally. And with always the possibility to consider deferral of AVR in selected patients. For example, depending on patient preference, if the patient has a normal exercise test we could consider, delaying AVR. Also, patients with unfavorable anatomy for TAVR and high surgical risk, marked frailty, short life expectancy, and also the asymptomatic severe AS patient with low gradient AS. And for those patients in whom we decide to defer intervention, we should do a proactive surveillance with a partnership between heart valve team, heart valve clinic eventually, and the referrer. And that should be more vigilant than the every 6 to 12 months. Ideally, every 6 months is better, or every 2 months in some cases. And for those who are finally categorized as moderate AS by the heart valve team, they also need a clinical surveillance and active clinical surveillance and a clinical trial testing AVR in selected patients. So we also try to address in this document the anticipated question and challenges, and we'll discuss further this question in the discussion period after the presentation. There are some challenges. For example, there might be concern about the reduced autonomy of the general cardiologist to manage a patient. I think we can overcome this limitation by engaging the general cardiologist in partnership with the heart valve team. Heart valve team may be overwhelmed by increased referrals. And I think this further reinforced the need for tailored protocol and simplified pathways. This shift toward early AVR may increase the economic burden. Well, there has been data, including presented in a late-breaking trial in this meeting by Philippe Généreux, that shows that the cost and length of stay are actually lower when treating asymptomatic patients at an earlier stage than later. Treating asymptomatic patients will exacerbate capacity constraints. Well, we believe this will be temporary, but because over time, we will simply be treating the same number of patients, but earlier and with less complication and lower cost. And this has just been published in JACC. Thank you very much.
Philippe, that was really excellent. Very difficult to summarize, but I mean, really what you said was we need to watch these patients more carefully. The diagnosis agnostic of symptoms of severe aortic stenosis, once confirmed, represents at the very least a medical urgency, maybe not a medical emergency, but that urgency should change the way we manage these patients and what our attitude is. Early referral, heart valve team focus, confirmation of the diagnosis, upstream preparation, and when all things are in place, careful discussion with the patient, and when a decision is made to move ahead, prompt AVR as perhaps the preferred therapy. And if you choose not to, for a variety of reasons, either logistic or social or medical, then still the surveillance cannot be passive. It has to continue to be active, proactive in fact, and very careful because we can't lose touch with these patients. But we also recognize that there are going to be some challenges. And I think that Philippe has begun to address some of those challenges. And we wanted to discuss that a little bit. Right now, when we circulate amongst the audience, we hear that the waiting lists are already too long. What are we going to do if we start unleashing the asymptomatic severe AS patients? And how are we going to be able to manage this logistically in our various geographies? So, Philippe, what is your response to that question?
First of all, beautiful work, Chris and Philippe and Brian and all the groups. So I will say that pain will be temporary, like you mentioned. And the big overarching concept is care avoidance or kicking the can down the road has never been cost effective. It's going to increase the cost like we demonstrate yesterday. So a strategy of early intervention is cost dominant compared to clinical surveillance, mainly because of the reduced heart failure hospitalization and free up bed. So if you have a waiting list and you keep treating patients that stay 5 to 7 days in the hospital, they come in acute valve syndrome or heart failure, this is where you will never be able to go through your waiting list. So you have to start somewhere. Start to refer your patient early, do the CAT scan, and start to put them in. And then you're going to be 1 day length of stay, 2 day length of stay. And also less complex cases. To come back to the case of Tanya and her team, the calcium score was 6,000. If you treat the calcium score earlier, and this patient probably had been severe AS for 4 years, if you treat earlier a calcium score at 2,000, it's way less risk of stroke, less pre or post deal, easier case, so you save money. So at the end of the day, you need to start somewhere, one patient at a time, refer the patient, and to intervene earlier in a less complex protoblast will save money. And we did this study in Europe with 9 countries, saving mainly €6,000 per patient treated earlier. So.
That's a really helpful series of comments. And I think you're right. I think we have the guidelines that have come to us now. And this document, this perspective, is about drawing a line in the sand and defining best and future, but honestly, we understand aspirational at this current state because of where we are. But the therapy has evolved and matured and been demonstrated to be beneficial. And it is incumbent on us to upskill, not in the lab anymore, because we've achieved that. The next gains for the treatment of this disease are on an operational level, to be able to deliver the therapy to the patients in the numbers that are required. And your key point about it being temporary pain is a really important one. These are not new patients, a completely separate population. It's merely the same population that we treat now, recently quantified in terms of prevalence in the Preview study. We know how many patients are out there. We're now simply bringing them forward in the care so that we're treating them when they are less sick and when the procedure itself is also potentially safer as well. Philippe Pibereau, you're obviously this huge expert in terms of diagnostics and imaging. You talked briefly about problems of misclassification of AS. How much of that is a problem in the real-world clinical practice?
It's an important problem, I think, and we often underestimate AS severity in most places, essentially because patients often present with low gradient AS, and we put a lot of weight and attention on the gradient, and sometimes the echo report only report the gradient and then not the rest of it. So that's why I think we should militate to have a complete report, including gradient, but also valve area, Doppler velocity index. And as soon as a parameter falls into the severe range, even if it's only one, if it's only the valve area, I think we should do more. The patient should be referred, and we should eventually do additional testing, and in particular, dobutamine stress echo if the patient has a reduced EF. And more, we're going to use calcium score in all categories of patients because it's faster and more straightforward, and confirm the stenosis severity. And this is particularly important in women because women often present with low gradient AS and will never develop high gradient AS. And so it's really important to pay attention to that and to look beyond the gradient and really be more comprehensive. And as soon as parameter suggests severe AS, or if the assessment by the echo is unclear, refer the patient.
That's really helpful. I think there's 2 important points you made there. One of which I want to say is also the idea of automated referral pathways. We saw in the DETECT-AS study just the simple intervention of an electronic notification increased the amount of AVR that was offered to appropriate patients. But to your comment around women, it also removed some of those inequalities that we know exist for patients when it comes to accessing AVR treatment. Ferdinand, do you have any worry that if we're moving into younger patients or indeed earlier in their disease process, that there's a concern of durability of either surgical valves or TAVI valves? Do we have data nowadays that help reassure us?
So I maybe one comment of you. I think we should refer the valve diseased patients on an early stage. So we need to see those patients regardless if they are MR, TAR, or aortic stenotic patients. If they are the referral clinicians are bonded to a clinic and to an interventionalist, that the patient can get the best out of it. It's a key thing. And to have a proper imaging that we can find the best clinical pathway, surgical or interventional. Regarding treating patient early, I think it saves complications that we would face later on. So if we treat patients early with normal left ventricular function, with no calcification in the LVOT. This was also one point, you pointed it out with the CT scan, that we didn't have any calcification in the LVOT, so less risk of pacemaker implant. That, of course, is another kind of argument for TAVI prosthesis in that case we saw. But the durability of the valve, of course, with the new tissue treatments, will give us a little bit more time. And of course, the first cut is the deepest, or size does matter in the patients when they are treated first. In TAVI prosthesis, we have to, or in bioprosthetic prosthesis, the need for a big valve that is big enough that we can avoid the Russian doll effect, and that we keep everything open for coronary interventions, re-interventions by TAVI. This is the key take-home message. But I think the avoidance of complications, we face patients with a lot of concomitant diseases on a later stage when they appear in our clinics. This should be avoided, and I don't think that it will be an economic effect or something like that, or that we have more patients now. They are not sitting around the corner and waiting for a valve treatment, in my opinion.
So I will say one thing which is reassuring in favor of early intervention is really the natural history of the disease. In early TAVR, and same thing in Catheter paper in 1977, at 1 year after seeing a patient with severe AS no symptom, 50% developed symptoms and 75% at 2 years. So the argument that you start the clock of tissue valve degeneration earlier, it's not really valid anymore, because actually if you need two valve, you will need two valve. You're not saving upfront a lot of time. You're not on your warranty of the valve. So I will say that this argument is invalid in a way that the natural history proves us that you're not going to save too much time. The second thing is intervening earlier with less calcium score would probably ensure optimal expansion and potentially improve durability. So to implant a valve in a calcium score of 1,000, it was much more pleasant than 6,000, and we'll have to see ensure optimal durability.
That's a really good point, and that's what the perspective does. It myth busts common themes that are misinterpreted about earlier intervention, and it provides an evidence base to support those statements. We're nearing the end, but I want to commit to what I said about answering your types of questions. And so, Kentaro, you and I have talked about the differences in Japan with longer life expectancy. And we have a question here saying, do you think then the cutoffs in age between transcatheter and surgery will have different applications in different parts of the world?
Thank you very much. It's quite important. See, actually, I was in charge of the valvular guideline in our country, and I checked the difference between the Japanese patient and European patient in terms of remaining life expectancy. There is only 1 or 2 years difference between European and Japanese patients. That means we don't have that long longevity compared to European patients. From my viewpoints, I think that it's quite important to use the same cutoff point as that of European. And of course, we also take into account the gender. And once the female gender have the longer longevity, so therefore we can tailor-make our decision to take into account not only the age, but also the gender or other procedural factor. That is my viewpoint.
Wonderful. Thanks so much, Kentaro. So we're nearly at time here, Marty. It's over to you to summarize.
Well, again, this has been a outstanding 90-minute segment. I think we've done really a nice job in framing the issues. I think that people are concerned that we're going to overwhelm the system by now introducing a host of new patients, so-called new patients, with asymptomatic severe aortic stenosis. Please recognize that even in the best established programs, the majority of patients with confirmed severe symptomatic aortic stenosis are not even treated in the first year. So by elevating the awareness of this disease, the urgency for prompt treatment, I think we do justice to what would be a better overall management strategy of all patients with aortic stenosis. We are not strictly exaggerating the importance of transcatheter technique Very careful in the guidelines and in this document is the discussion of AVR, because surgery is very good. And the next question I always hear, are we trying to put surgery out of business? We're not trying to put surgery out of business. And the reality is Michael Borger was here yesterday and said that his surgical volume has gone up since we've elevated everyone's awareness of the importance of aortic stenosis. And by the way, there's a lot more to be done. We still have a lot of questions. We don't really understand so well how to manage many of these bicuspid, earlier stage patients. We still don't know with certainty how to manage some of the younger patients where there may be more accelerated bioprosthetic valve failure. We're not certain. This discordant diagnosis that Philippe keeps pointing out still in the community is something that we're dealing with. And there are patients that have AS in association with other concomitant diseases that we also have to consider. So I view this as an inflection point. We have a lot more to do. We have a lot more studies to look at and evidence to accumulate. But I think having this kind of management pathway paradigm, which forces us to refer patients earlier, to get an accurate diagnosis quickly, to be proactive with regard to having all the appropriate tests done so you can react quickly and do AVR more promptly, can only be beneficial to patients. And I think if this could be generalized, it would make a very, very important difference in the overall treatment of patients with AS. And I'm hoping that this kind of session will, again, increase the dialogue. We can communicate. In different parts of the world, things are always different, and we need to mitigate against those differences. But I think putting the patient first and trying to come up with what we think is an optimal therapy and then making adjustments around that to manage logistics is the right path to take. And I really feel privileged to be part of a group that thinks in this constructive way on how to manage patients.
Thank you very much. And most importantly, thank you very much. Enjoy the rest of your congress. And if you're heading home, safe travels.